to talk today regarding how to use the oxytocin. Some healthcare organizations like American College of Obstetric Gynecology created checklists. Patient safety checklist is important, through which you can revise the patient's data. Patient name, birthday, who is the responsible person, who decided about the induction of labor, estimated date of delivery, and the purpose of the induction, as well as the gestational age of 39 weeks or older, confirming by either the following criteria, either by early ultrasound before 20-week gestation or fetal heart tone have been documented as a presence for 30 weeks of gestation by Doppler ultrasound. Other thing we will find it in the patient safety checklist is the indication of the induction, whether it is these patients have been induced due to the medical complication, and this medical complication should be mentioned either diabetes, hypertension, or any other complications, or the non-medical indication like the patient wishes to deliver in specific day. Patient counseling about the risk, benefit, and alternative to the induction of labor should be documented clearly, and the consent should be taken from the patient. Bishop score will talk about this later in this lecture, but it should be calculated according to the dilatation, position of the cervix, effacements in the station, and cervical consistency. So there is a specific lab result according to the institutions. Each institution will choose their specific lab result. Minimally, there should be hemoglobin or hematocrit plus screening for group B streptococci. You know that if there is this, if you are following in your institute, you are not following the screening for all the population, then you have to cover your patients according to the protocol of labor room. A special concern like allergy, medical problem, and special need should be also documented. Pre-induction evaluation includes reviewing the estimation of gestational age, determining fetal presentation and lie, estimated fetal weight by ultrasound as well as clinically, and perform cervical examination to decide whether the cervix ripening agent is mandated, evaluating the fetal heart rate pattern, and reviewing the patient pregnancy medical history, past obstetrical history, the factors which might be problematic during the labor and delivery. Factors assessing the success of induction of labor. There is cervical status factor and there is non-cervical factors. In this slide, we are talking about the cervical factor. We are going to assess the cervix by Bishop score. Bishop score system is a system which is involving in assessing the cervical dilatation, effacement and the station of the head, as well as cervical consistency and positions of the cervix. If the cervix is closed, then it will be scored 0. If it is 1 to 2 cm, it will be scored as 1, and if it's 3 to 4 cm, it will be scored as 2. But if it is more than 5 cm, it will be scored as 3. If the cervical effacement is 0 to 30%, it will be scored as 0. If it's 40 to 50%, it will be scored as 1. And if it's 60 to 70%, it will be scored as 2. And if it is more than 80%, it will be scored as 3. If the head station is -3 station, it will be scored as 0. -2 station, it will be scored as 1. -1 station, it will be, or 0, it will be scored as 2. And +1 and +2 will be scored as 3. Cervical consistency. Firm cervix will be scored as 0. Medium cervix will be scored as 1. And soft cervix will be scored as 2. Position of the cervix, if it is posterior, it will be 0. If it is mid-position, it will be 1. And if it's anterior, it will be 2. Adding all these factors together, if you ended up by Bishop score more than 6, you will consider the cervix as favorable cervix and you can start the oxytocin without cervical ripening agents. But if the Bishop score is less than 3, as unfavorable cervix will be diagnosed, the cervical ripening is preferable before you start the patient on oxytocin. So Bishop score of 4 to 5 are in the gray zone. You have to revise the patients, revise all the indications, and if you could delay the induction of labor, then till the Bishop score is better, or if it is mandatory to induce the patients, then you go ahead and give the patients cervical ripening agent like prostaglandin. Non-cervical factor, like multiparous women, women at term gestation, or patients with rupture membrane, patients with a low body mass index, and taller patients, and the patient have infant estimation less than 4,000 grams, and women without comorbidity associated with placental insufficiency, example, preeclampsia. Medical indications for induction of labor. Induction of labor is indicated whenever we decide and we see that the delivery of the fetus is going to reduce the maternal mortality and morbidity comparing keeping the fetus in utero. And this is occurring in certain situations like post-term pregnancy, patients with pre-labor, premature rupture of membrane, patients with preeclampsia, eclampsia, with chronic hypertension, gestational hypertension, if there is a fetal demise or there is a fetal growth restriction, patients with chorioamnitis, oligohydramnios, cholestasis, and aluminization with fetal anemia and twin pregnancy, and more than this all. When we are talking about any intervention, like starting the patient on oxytocin, there is nothing safe 100%. You have to look for the contraindication of any procedure or any medication you are giving to your patients. So the contraindication for oxytocin, it could be related to the mother, which is contraindication, maternal contraindication, or contraindication due to using the oxytocin might affecting the fetus. So contraindication related to the mother, like prior classical cesarean section or uterine rupture, or if you entering the transmural uterine incision, entering the uterine cavity during myomectomy, invasive cervical cancer, all of this and more could be and contraindications for using of oxytocin. Active genital herpes infection, placenta previa or vasa previa, umbilical cord prolapse, transverse fetal lie, category 3 fetal heart rate tracing could hurt the fetus. So this could be a contraindication due to the fetal causes. To talk about the technical point on initiating the protocol for oxytocin. If you want to initiate the protocol of oxytocin, you might read a lot of book. There is different protocol. There is low dose protocol and high dose protocol. In low dose protocol, we have the 1 to 2 milli international unit per minute, and increase by 1 to 2 milli international unit per minute every 15 to 40 minutes, and this will be according to the if it is prime gravida or it is multigravid and previous scar. Usually we are increasing every 30 minutes, 15 to 30 minutes in prime gravid. We are increase 30 to 40 minutes in multigravid, and this will be depending on the evaluation of the fetus, the evaluation of the contractility of the uterus. In high dose protocol, we are starting in 6 milli international unit per minute, increasing by 6 milli international per minute every 15 to 40 minutes. And if you are asking me which one you prefer, I prefer the low dose protocol. And I would tell you why I prefer the low dose protocol, because high dose protocol associated with reduce the induction to delivery interval, that's true, but there is no difference with the rate of the cesarean section compared to the low dose protocol, and the higher rate of the tachysystole, which might pushing the physicians to rush for cesarean section, and there is no difference in the perinatal complications rate between the high dose and low dose protocol. But in low-dose protocol, you are giving the chance for a successful normal vaginal delivery to go within the normal rhythm rather than to rush the patients for tachysystole. How to calculate the low-dose protocol? Before we calculate the low-dose protocol, there is fact to remember. You have to remember that each 1 cc is contain 15 macro drop as well as 60 micro drop. Usually what we are using 10 units syntesinone in 500 cc ringer lactate. If we are mixing the 10 units into in 500, if you want to get rid the milli international unit, so we will get the 1 unit. So divided by 10, both sides, we are getting 1 unit is equal to 50 cc. So this is 1 unit. What about milli international unit? So we have to multiply by 1000 to change the 1 unit to milli international unit. So 1000 milli international unit will be equal to 50 cc. If you want to calculate the 1 milli international unit, we will divide it by 1000 and it will be 50 divided by 1000, it will be 1 over 20. So every 1 milli international unit equal to 1 over 20 cc. If you want to convert it to microinfusion, microdrop, then we will multiply it by 60. Remember that 1 cc equal to 60 microdrop per minute. So 1 milli international unit equal to 3 microdrop per minute, which is equal to 3 ml per hour. Now we know that 1 milli international equal to 3 microdrop per minute, which is 3 ml per hour. We know that the maximum dose of oxytocin is 40 milli international unit for primogravid and 32 milli international unit for multigravid and previous cesarean section. So 40 milli international unit is equal to 120 microdrop per minute, and 32 milli international unit is equal to 96 microdrop per minute. This is an example of the protocol which we are using 10 units syntesinone and 500 ml normal saline or ringer lactate. Remember that don't initiate syntesinone for 6 hours following administration of vaginal prostaglandin gel and half an hour after propes. And remember, don't also start oxytocin when you rupture the membrane. You need to wait for 1 hour, avoiding the tachysystole. Why we have to know these calculations? We have to know this calculation because certain situation like patients who is preeclampsia on magnesium sulfate, and we know that this patient cannot run with a very high amount of fluids. We have to restrict the amount of fluid to 100, sometimes 85 cc per hour. So if you have to give the patient the magnesium maintenance dose around 100 cc per hour, so how you are going to induce the patient with syntesinone? Either you are going to double the concentration of the magnesium sulfate and giving the patient instead of starting the patients on 100 cc per hour, which equal to 1 gram or 2 gram according to the protocol which you are using. You have to adjust that and double the concentration of the magnesium sulfate, so you will get 50 cc instead of 100. Sometimes there's certain hospitals and certain protocols in the hospital you cannot adjust because it's coming ready mixed from the pharmacy, so you can playing with your oxytocin concentration. Instead of putting 10 cc in 500, you can place 20 cc in 500 and lower the ml which you are using. So according to the situation, you can play with the concentration you are using.